Most people believe that when a surgeon hands you a consent form, the decision has already been made. The doctor weighed the options. The hospital is ready. Just sign here. I used to believe that too, until I started counting the patients who went in walking and came out changed. Not better. Changed. Raymond, a 74-year-old man, went in for a spinal fusion on a Tuesday morning. He came out unable to feel his left foot. That sensation never came back. He went from hiking on weekends to needing a walker. The fusion was a technical success. Raymond's life was not. Lorraine, a 79-year-old woman, had an elective hip replacement, healthy enough on paper. On day 4 of recovery, a blood clot traveled from her leg to her lungs. Her family was called in. She survived 11 days in the ICU and spent the next year rebuilding a body that had been through 2 battles instead of 1. Here is what nobody tells you. For people over 60, the older your body is, the harder it fights just to survive an operation. Not the disease, the operation itself. The surgery is not always the most dangerous part. It is the recovery. And those are 2 very different things. My name is Dr. Michael Whitman. I am a board-certified general and vascular surgeon with 24 years in operating rooms across 3 major medical centers. I have recommended surgery when it was the right answer. I have also looked patients in the eye and told them the operation on the table was not one I would choose for someone I loved. Today I am telling you the truth about 5 surgeries that carry serious hidden risks for people over 60, the research behind each one, the alternatives that rarely get offered, and 4 questions every person over 60 must ask before signing any surgical consent form. Now, I want to be absolutely clear about something. Age alone is not a reason to avoid surgery. I have operated on 70-year-olds who bounce back faster than some 50-year-olds. Age is just a number, but frailty is not. Frailty is a medical term. It means the body's reserve has dropped below a critical threshold. Roughly 40% of people over 75 show signs of frailty. That number jumps to nearly 60% over 85. So, here's the real question. It's not whether someone can survive the operation. It's whether they can survive the recovery. Those are 2 very different things, and that distinction is going to matter a great deal right now. Surgery 1. Open heart surgery in frail patients, coronary bypass surgery, CABG, is one of the most common major surgeries performed on older adults. For the right patient, in the right condition, it is life-saving. I have performed it, and I believe in it. But open heart surgery requires stopping your heart completely. A bypass machine takes over while we operate. For a 62-year-old in excellent health, that is manageable. For a 79-year-old with kidney disease, cognitive decline, and heart failure already present, that machine is a simultaneous assault on every organ at once. The brain is especially vulnerable. Microemboli released during bypass cause what doctors call post-operative cognitive dysfunction. In patients over 70, published research shows it occurs in up to 50% of cases. In many of them, the changes are permanent. A study in the Journal of the American College of Cardiology found that frail elderly patients faced a 30 to 40% risk of major complications from open heart surgery, stroke, kidney failure, extended ventilator time, and up to 15% did not survive the first 30 days. That is 1 in 7 people. What most patients in this group are never told. An alternative often exists. TAVI, transcatheter aortic valve implantation, addresses significant cardiac valve disease without stopping the heart or opening the chest. A catheter through a blood vessel. No bypass machine. Far kinder to a body with limited reserve. One question to ask before any cardiac surgery discussion ends. Am I a candidate for a catheter-based approach? That single question can change everything. Have you or someone you love ever been told open-heart surgery was the only option? Tell me in the comments. I want to know how many of you have been in that room. Surgery 2. Aggressive spinal fusion back pain in your 60s and 70s is nearly universal, and the surgical solution being offered with increasing frequency is spinal fusion, permanently joining two or more vertebrae with rods, screws, and bone grafts. Some spinal surgeries are essential. Active spinal cord compression causing paralysis or loss of bladder control. That needs immediate surgical intervention. That is not the surgery I am talking about. I am talking about elective multi-level fusion for chronic back pain, and the evidence here is genuinely troubling. A major study in the journal Spine found that patients over 65 who underwent complex spinal fusion had a complication rate exceeding 40%. Blood clots, infections requiring reoperation, hardware failure, and adjacent segment disease, where the vertebrae above and below the fusion begin breaking down at an accelerated rate because the entire mechanics of the spine have been permanently altered. The most important finding, for many elderly patients, aggressive spinal fusion provides no better long-term pain relief than structured physical therapy combined with targeted injections. No better outcome. Dramatically higher risk. Before agreeing to any elective spinal procedure, ask directly, what is the evidence that surgery will relieve my specific pain more effectively than conservative treatment? Listen carefully to how specific that answer is. Have you ever been told surgery was your only option for back pain? Write it in the comments. I want to know how many of you have heard those exact words. Surgery 3. Major cancer resections in frail patients. When someone hears the word cancer, the instinct is powerful and completely understandable. Remove it. Cut it out. I would feel the same. But the goal of cancer treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. And sometimes, more often than anyone publicly admits, major surgical resection in a frail elderly patient achieves the first, while failing at the second. The Whipple procedure for pancreatic cancer takes 6 to 10 hours. It removes the head of the pancreas, a portion of the small intestine, the gallbladder, and part of the bile duct. In younger healthy patients, it can extend life meaningfully. In an 82-year-old with heart disease and reduced kidney function, the tumor may be removed, and the patient may still pass away within weeks. Not from cancer, from the surgery itself. A study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what researchers called failure to rescue, a complication the weakened body simply could not survive. The conversation worth having. If we do not operate, what does watchful waiting, targeted radiation, or systemic therapy look like for my age and health profile? That question opens a door many patients never knew existed. Sometimes what is behind that door is genuinely better than what the operating room offers. And this is not about giving up. This is about choosing the path that actually serves the life you want to live. Surgery 4. Elective joint replacement in severely ill. Patients' hip and knee replacements are among the most successfully developed surgeries in modern medicine. For the right patient, they are life-changing. People go from barely walking to playing with their grandchildren. I believe in these operations, but the word elective carries meaning most patients never stop to absorb. Elective means planned. It means you have time to think, to prepare, and to ask whether this specific moment is the right moment for your specific body. For patients over 75 with 3 or more concurrent conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries substantially elevated risks that are rarely discussed in the pre-surgical consultation. Deep vein thrombosis is the most immediate danger. Clots that form during or after surgery can travel to the lungs, becoming a pulmonary embolism, a life-threatening emergency. In elderly patients with reduced circulation, this risk is significantly higher than in younger patients. Add postoperative pneumonia from immobility. Add hospital-acquired infections. Add the cognitive burden of anesthesia on a brain already managing age-related changes. The question is not whether to ever have a joint replacement. It is whether your body is in the best possible condition to receive it right now. Ask your surgeon about prehabilitation, a structured program of strengthening, cardiovascular conditioning. EDAN metabolic optimization before surgery is scheduled. It reduces complication rates dramatically. Most patients have never heard the word. They absolutely should. Surgery 5. Emergency abdominal surgery. This one is different. You do not choose emergency surgery. A perforated bowel, a ruptured appendix, internal bleeding. These do not wait. They arrive at 2 in the morning. But knowing the risks before the emergency happens changes everything about how families make decisions in those terrifying moments. And knowing what leads to these emergencies gives you the power to prevent them. Emergency abdominal surgery in patients over 75 carries in-hospital mortality rates between 30 and 50% in the most severe cases. An elderly body under sudden severe trauma is fighting on too many fronts at once. The inflammatory response that a younger body resolves in days can spiral into cascading organ failure in a body with depleted reserve. 2 things to do right now, both completely within your control. First, do not ignore abdominal symptoms. Persistent pain that keeps returning. Unexplained changes in bowel habits. Bloating that does not resolve. Blood where it should not be. In someone over 60, these are signals that deserve a same-week appointment, not a wait-and-see approach. Catching diverticular disease, colorectal cancer, or an aortic aneurysm in its manageable phase means treating it with a prepared, scheduled procedure. That difference is the difference between a 5% complication rate and a 40% mortality rate. Second, have the conversation with your family now, not in the hospital corridor at midnight. Now. What are your wishes if emergency surgery becomes the only option? What quality of life matters most to you? These conversations are not morbid. They are one of the most loving things you can do for the people who will be standing in that corridor. I want to tell you about a patient named Desmond, 73 years old. Retired high school principal, the kind of man who brought a typed list of questions to every appointment and expected a complete answer to everyone. 4 different surgeons had recommended open-heart surgery. 4 opinions, the same answer every time. Desmond wasn't afraid of surgery. He was afraid of something specific. 2 years earlier, he had watched his brother go through a major cardiac procedure. His brother survived. But something changed. A subtle cognitive drift, forgetting things he had always remembered, and losing the thread of conversations he would previously have led. He sat across from me and said, "I have spent 40 years teaching young people how to think. If I lose that, I don't know who I am anymore. Tell me what that risk actually is for me, not in general, for me." I spent 55 minutes reviewing his complete profile, kidney function, frailty score, cognitive baseline. And I told him the truth. His specific numbers showed comparable 5-year outcomes between surgery and an optimized medical management protocol combined with cardiac rehabilitation. He chose the non-surgical path. That was 3 years ago. Last spring, Desmond sent me a photograph. Standing at the rim of the Grand Canyon with his 2 daughters, both of whom had flown in from different states to hike it with him, grinning like he won the lottery. But the caption read, "Still thinking clearly, still here. A surgical recommendation is not a verdict. It is the beginning of a conversation. Before any major surgery, every person over 60 needs to ask 4 questions. Write them down before you go in. Question 1. What happens if I do not have this surgery? If nothing urgent changes in the next 6 to 12 months without intervention, you have time to think, to seek another opinion, to optimize your health. Question 2. Is there a less invasive alternative? Robotic surgery, endoscopic procedures, catheter-based interventions, options that did not exist a decade ago, are now available at most major medical centers. Ask specifically. By name if you have done your research. Question 3. What does recovery realistically look like for someone of my specific age and health profile? Not the average patient. You, your heart, your kidneys, your medications, your living situation. If the answer sounds generic, say so. Question 4. And this is the one most people never think to ask. What is your personal complication rate for this procedure in patients over 70? Surgeons track these numbers. A confident, honest surgeon will tell you. If the question causes discomfort, that reaction itself is information worth having. Now let's bring it all together. 5 surgeries, 5 conversations most patients never have before it is too late. Open heart surgery in frail patients, where catheter-based alternatives now exist and are rarely offered first. Aggressive spinal fusion, where the pain relief evidence is far weaker than the surgical recommendation suggests. Major cancer resections, where the goal must always be more good years, not just a tumor removed on a scan. Elective joint replacement, where timing and preparation are as important as the procedure itself. And emergency abdominal surgery, where the most powerful intervention is catching problems early and having honest conversations before the crisis arrives. Surgery saves lives every single day. I have seen it. I have been part of it. I am proud of it. The message is simply this: be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion and, if necessary, a third. The surgeon holds the scalpel. You hold the choice. And that choice, made with full information and clear eyes, is the most powerful instrument in medicine. Well, what is the one question you would most want to ask a surgeon before a major operation? Tell me in the comments below. I read every single one. If this helped you or someone you love think more clearly about a surgical decision, like subscribe, comment, and share it today. That one share may be the most important thing you do all week. Take care of yourselves. Stay curious. Keep advocating for your health. I will see you in the next video.